Thanks, Dr. Yahya, and I'm happy that everyone is here. I'm happy with the full room. I hope you are enjoying the meeting. So I will present a case. It was disruption of the iris lens diaphragm and how we recover the lens and the iris tissue also. So I have no financial disclosure, but these are my disclosure to company that I'm a consultant and a speaker to them. So the case data is a male patient, 65 years old, severe blunt trauma since 10 years. History of drop of vision was gradually after trauma since 10 years. And on examination, there is a dense cataract with 1/3 of atrophic iris tissue. The rest of the iris shows some patches of iris atrophy. And I was thinking that the plan was to restore the bag of the cataract after the cataract remover, support the zonules, and restore the iris and the pupil. So let's go for the video. So these cases is very crucial that you plan your surgery and plan your openings in the anterior chamber. We have nearly 1/3 of the iris lost, and we should repair. But these cases with a long-term duration iris atrophy, they need a special instrument to be inside the eye. So proper removal of this fibrous tissue, because this area has no iris tissue anymore. It's a fibrous tissue. So with the micro scissor, we try to remove as much as we can, but not to remove the normal tissue, because we need this tissue to be repaired. So I'm removing as much as I can. Then once I finish this, I try to dilate the iris because I need to see the lens properly, because there's a trauma, and when there is a trauma, expect problem anytime. So I did a proper access for this patient, and any case of trauma, you should put a CTR because it's a very long trauma. Either you have a zonulosis or not, but this is crucial in trauma, long-term trauma with a damage inside the eye. I love the manual. I don't like the autosert because I love to guide it. But sometimes it can happen that you can not properly put the lens inside the eye like this. But I did. I succeeded. Remove the iris. Before you start to restore the iris, you should put the mycol, and you should know when you are going to start with the iris tissue. Start from the area with still there is an iris, and there the other side the iris, and never ever overstretch, because the iris tissue is atrophic and you can do an iris disinsertion very easily. So when this is my technique, 4-through pupilleplasty by Amara Goral. I think he changed the way of the iris repair. So 4-through and slowly, just tightening to reach just opposition. Don't do too much, and take as much as you can sutures. You are not supposed to close it because there is a fibrous tissue, but try to close as much as you can. But again, never ever overstretch during the iris repair, because the iris in this area is always very weak, and this insertion is easily to happen. So you are not going to complicate your case. This is the most important. Never to complicate your case. Take 1, 2, 3 sutures till you restore as much as you can the pupil. Sometimes you cannot reach the rounded pupil in these cases, but if you are closing as much as you can reach an appropriate shape of the pupil. So again, 4-through pupilleplasty, 1 knot, 1, 2, 3, 4, and you slide the knot, done like this. Again, Ammar changed the way for iris repair suture. This is in my opinion, and make it very fast to repair. Close everything. Then, my take-home message, very important. Proper history of the patient is important. Expect everything in traumatic cases. Micro-instrument should be prepared, and the delicate handling of the iris tissue, because it's already damaged in traumatic cases, is mandatory to reach the proper iris repair. CTR mandatory for stabilization of the integrity of the bag, and restoring the pupil and the iris is crucial for visual quality performance. Thank you so much.
Good afternoon, everyone. Thank you so much for the opportunity being here, and thank you for attending. It's great to see a full lecture hall. My name is Ahmed Sallam. I work in Arkansas in the United States. So I chose a case to match with the theme. This is a patient who presented with hypotony post-trauma. So this kid, was hit to the eye, and he came to us with hypotony. And when this happened, the important thing is to exclude that there's a ruptured globe, there's an open globe leaking. But in this boy, there was not, and we could see the hyphema. We also found a cyclodialysis on gonioscopy. And he was not under my care, and he was followed up by another team, hoping that the cyclodialysis would close with atropine, but it did not. And with the area of cyclodialysis, as you can see, there's also an dialysis as well. Here is the B scan from the clinic, and you can see the cyclodialysis cleft. And of course, the vision is very poor because of hypotony and hypotony maculopathy. Here's the gonio scan, and you can see the area of cyclodialysis lower down there. So I had the glaucoma specialist with me, and she wanted to try transscleral diode to close it. In my experience, transscleral diodes work well for small dialysis. Also, cryo works well for these ones, but when it's big, you cannot really do with laser or freezing. So the problem and the challenge in this patient is that he was phakic, and he was a kid. If it was an older patient, we would have sacrificed the lens, but he was a kid, 10 years old. So we've made marks, and there was vitreous prolapsing, even to complicate things further, and steps here to be able to do anti-vitrectomy, and there's an area of zonular dialysis there. Now we're using viscoelastic, put the iris back, and the challenge now is to suture that without hitting the lens. And usually we would do it without a forceps, so we'd do it like catching it with a needle and out, but the problem is here you want to be able to have like more fine movements because not hitting the lens, again, in a phakic patient. And sometimes I do flaps and sometimes I don't do flaps and I just bury the needle, but here, again, because of the difficulty of getting like accurate exits, I thought it's best to do flaps because we might not be able to bury all the sutures. And when the dialysis is big, something I've learned is to try to do more sutures, because if you don't do enough sutures, you'll not be closing enough. And I encountered that with another case. So here we did 3 sutures, 1 in the middle and then 2 on each side and out under the flap. And these are Prolene sutures. And I also do it with Gore-Tex sutures now. And then more sutures here. And then these sutures are tied and buried. We had to repair one. The problem we found is, of course, because you got the iris this way, now you've treated the cyclodialysis, but the iris got more peaked. So just for functional, we put the iris back with 1 suture here. So just to try to get it rounded. And again, usually you don't need to make it that complex, and you can just get it with the needle with the help of a cannula to support the iris. But here the issue is he's phakic, so that's why we did a bit more meticulous here. And then putting the needle here, and similar to what Ashraf showed before. And then out, and then we do the Sipser for knots repair, which again simplified the technique so much. And then hydrating the wound. And the patient did fantastic, and the fistula closed and his pressure went up nicely. This is another case. I just want to show you another way of repair. This is in a context of vitreous hemorrhage, vitrectomy, and hypotony because of cyclodialysis. So here, this patient also had a drop lens from the trauma, and he had a giant retinal tear as well, which you'll see in a minute, just to make things more difficult. So after repairing the the vitreous and removing the lens. We mark here the area of the cyclodialysis. And here it's easier. You can do it from the other way. Again, the patient is phakic, so it's easier. So you can go from the other way.
You can give him
Yeah.
1 minute.
Yeah, 30 seconds. And this is just a neater way of doing it, is through because then you're not catching the cornea, is using a trocar to pass the needles. And then in this case, again, the patient was pseudophakic, so it was easy to pass the sutures, and you can just bury the sutures. So we did not need to use a flap like this. I think my conclusion slide is, if you have hypotony post-trauma, you want to make sure that there's no overfiltration, either a wound or a cyclodialysis or retinal detachment or under secretion as a ciliary shutdown, or the patient is on medications, because we had a case where the patient actually was on using extensive drops, and we did not know that this patient was on IOP lowering drops. Thank you so much.
Thank you. Thank you very much, Dr. Ahmed.
Thank you again. This is a young female patient with open globe injury. Cornea, iris, and anterior capsule are lacerated by a knife. Her fellow eye is normal with astigmatic correction. As you already know, urgent reparation is needed. However, I want to ask at that point, would you proceed with cataract surgery simultaneously as anterior capsule is lacerated? Or would you repair the iris at the same session? We choose to proceed with sequential surgeries, and as the second session, while the inflammation subsided and risks of endophthalmitis disappear, and cataract lens was hydrated from the open capsule. And as a third procedure, now the patient is aphakic, iris is damaged, and there is synechia. The pupil is ectopic to the lacerated quadrants. And what we are going to do, we have to make a decision. There is a clear central cornea, and we decided not to do keratoplasty at that point. And we proceeded with pupilloplasty and scleral fixation. After scleral first synechia were released, and IOL was implanted with PC9 Prolene suture, and pupilloplasty was performed. At the end, visual acuity improved to 0.4 with astigmatic correction. You see a nice and central pupil. And here comes another question. The normal eye also has astigmatism. However, we see in the topography picture that the topographic astigmatism is high as 10 diopters. And are we going to stop at that point, or would you go on with corneal refractive procedures to correct that astigmatism? The family of this young lady was very anxious, and they visited all the experienced doctors in Ankara to find the best doctor. And we chose to stop at that point and leave the eye in this quiet situation. However, maybe we can discuss at the discussion, and your opinions are worthwhile here. Whether to stop at that point or proceed with some refractive procedure. Thank you for your attention.